less documented area of spine surgery. That's treatment of lumbar spinal stenosis. However, there have been a group sitting scrutinizing the literature, and I'll very much refer to that. That is the North American Spine Society, NAS, evidence-based clinical guidelines for multidisciplinary spine care, evaluating the diagnosis and treatment of degenerative lumbar spinal stenosis. Of course, we all know when we are performing a spinal procedure, we have to do the right patient selection, and of course it's also to define which patients are benefiting from a surgical procedure and which technique are we going to use. Also, the performance of the surgical technique, that's pretty difficult to have evidence-based because we always want to do it best, but of course surgical techniques can be modified, but then maybe it's a change in surgical method. However, biological factors are very important. Which patients should we not operate due to comorbidities and things like that? So all these factors have to be put into both consideration and subsequent research. If we, for instance, take a simple problem like chronic low back pain, the balance between conservative and surgical management is very difficult. With spinal stenosis, of course, it gets a little more unclear because some patients may be able to live with their condition. However, also in spinal stenosis, there are a number of different treatment options, ranging from foraminotomy, laminectomy, some interspinous spacers, and then, of course, there is a choice of combination with fusion. We looked also Cochrane Library, and there is within a spinal stenosis treatment, there is very limited support, and I will come back to that. I just inform you about my mentor, Niall Nachemson. It also goes for lumbar spinal stenosis, as we have here a patient treated for spinal stenosis with a lumbar fusion, primary uncomplicated, but then after 2 years we had to elongate the fusion and decompress adjacent level, and then after 2 months there was a major failure, and of course this is dramatic. The patient can't move. Many solutions you could think of, but a very good one was chosen by our surgeon Ebbe Stender Hansen, who actually went in here to do a wedge osteotomy and elongation of the fusion and protective vertebroplasty. The patient did become mobilized again. But of course, this is not evidence. This is really just to do it. But the evidence-based question here should be whether fusion was indicated from the beginning in 2001. So the question here is really consensus-based medicine versus evidence-based medicine. And if we look at the definition of evidence by this group, of course, level A evidence is good evidence, where we have so-called level 1 studies, more than two or more, with consistent finding with no disagreements. Fair evidence is level 2 and level 3 studies. That's called B evidence for or against an intervention. Level C, that's poor quality evidence for or against recommending intervention. Insufficient or conflicting evidence is classified as I, and not allowing any recommendation for or against intervention. In orthopedics as a whole, we have fairly limited randomized prospective studies compared to other specialties, as I described yesterday. If we look into the subspecialties of orthopedics, spine is doing quite well, but still, when we compare to cardiovascular surgery, there are very limited evidence, randomized prospective studies, up to 20% of what they have in cardiovascular surgery. If we go back to the subject, the spinal stenosis, of course we must agree on the best working definition of degenerative lumbar spinal stenosis, which is ascribed as a condition, syndrome of buttock and lower extremity pain, which may occur with or without back pain, associated with diminished space available for neural and vascular elements in the lumbar spine. Symptomatic spinal stenosis has certain characteristic provocative and palliative features. The provocative features include exercise and positionally induced neurogenic claudication, and palliative features commonly include symptomatic relief with forward flexion, sitting, or recumbency. So the work group consensus here is that what is the natural history of degenerative lumbar spinal stenosis? The natural history of patients with clinical mild or moderate degenerative lumbar stenosis can be favorable in about 1/3 to 1/2 of our patients. We should inform the patients about this natural history before we dig into surgery. This has a level 2 evidence, this saying, and that's the strongest that we get at all within the management of spinal stenosis, as you will see later on. And it can also be assured to the patients that the patients with mild or moderate degenerative lumbar stenosis, they are not likely to have rapid or catastrophic neurological decline. So this is also a comforting statement to give to the patients. But what are the best way to make the diagnosis? Of course, we know MRI is what we use every day, so this has a uniform high, but not level A. It has a level B significance. What are the appropriate outcome measures? This includes, of course, the outcome questionnaires like Oswestry Disability Index, Swiss Stenosis Questionnaire, Zurich Claudication Questionnaire. These are appropriate measures, and it also has the strongest recommendation or the strongest evidence which we can get here. On the other hand, other systems to evaluate this condition has only insufficient evidence. What about medical intervention? Do medical treatments improve outcomes in the treatment of spinal stenosis compared to the natural history? And the literature really gave no answers to this question. But what about pharmacological treatment in the management of spinal stenosis? Here there were a little evidence with intranasal calcitonin, intramuscular calcitonin, and other drugs which did provide long-term benefit. Again, recommendation B. What about physiotherapy? With this, the literature was not able to give any recommendation. As for chiropractor treatment of spinal stenosis, there was no evidence for any recommendation here. Surgical treatment. Does surgical treatment improve outcome in the treatment of lumbar spinal stenosis compared to natural history of the disease? And the statement that in patients with severe lumbar stenosis, the decompressive surgery alone is effective in approximately 80% of the time. This has an even weaker recommendation level, C recommendation level. So this is not so strong really. Patients with moderate to severe symptoms with spinal stenosis, surgery is more effective than medical and interventional treatment. Again, a C. and if it comes to mild symptoms, surgery will be effective in 70% of the time. Again, a quite mild recommendation, a C. So really looking into the long-term effect of this decompressive surgical treatment, again, we are getting a little better with a recommendation of B for long-term effect in these patients. So, but when it comes to whether surgical decompression alone improves surgical outcomes in the treatment of spinal stenosis compared to medical and interventional treatment alone, or the natural history, we have the saying of 80% with a benefit for surgery and 30% a benefit of conservative treatment. Recommendation C, C, and C. It's just a repetition of the previous slide. What about the interspinous device, X-stop, diam, whatever? And at the state of this report, there is insufficient evidence that this will change, although there was a so-called level 1 study, but only one study of this high level, and that made the conclusion insufficient for a recommendation of this interspinous device. We know later from data from other studies that this interspinous device, is subject also to a high number of reoperation rates. So I think that our concept of making cost-effectiveness evaluation of this device would be very profitable to come closer to the true evidence. What about the addition to the decompression, the addition of fusion when doing the decompression? In patients with lumbar spinal stenosis and spondylolisthesis, decompression with fusion results in better outcome than decompression alone. This is a recommendation B. What about if you see pseudarthrosis following this this procedure? This is still a grade B recommendation that it doesn't affect the outcome. So you should not maybe be so eager to go in if you see a pseudarthrosis in these patients. For the presence of pseudarthrosis on radiographs following lumbar fusions in patients with spondylolisthesis, this negative effect, however, cannot be controlled, or it cannot be recommended as for any decision making. There is insufficient evidence that the long-term result of the pseudarthrosis present on the radiographs that will affect the outcome. So, in general, the addition of instrumentation to posterior fusion increase the radiographic fusion rate. That's the strongest saying here in this patient group. So, however, in patients with lumbar spinal stenosis without spondylolisthesis or signs of instability, there is no evidence to support the addition of a fusion, but this is not to be, this cannot be concluded. There is insufficient evidence to control this, this advice. The long-term management, however, what is the long-term result of surgical management of spinal stenosis? The long-term result of this procedure are good or excellent in 50 to 79% of the patients, and this is a fairly weak statement if you are going to convince the patients for surgery. So, but you are not able really to have a high recommendation grade. The evidence or the level of evidence is a C. So altogether, this report and the scrutinizing of this literature is quite uniform in existing problems. We have small sample size, we have non-validated outcome parameters, we have crossovers, and we have many examples of studies. People start out with a randomized controlled trial, and then they just put some more patients in, change the groups, whatever, you know. So this is really also a problem. The presence of non-validated outcome parameters actually put 2 randomized studies into a level 2 group from intentionally level 1 group. So we can clearly advise people really to look through the quality markers when they are doing when they are setting up such a study, not to end up in this inferior category of science. So with this, I would just like to stress on the problems with the total cost of our treatments and the need for doing a more thorough investigation of the costs, to add the cost to the procedure, to the outcome of the procedure, and try to do a cost effectiveness, because I really think that this will give a much more firm information than what we have heard today from the otherwise good conducted randomized controlled trials. Thank you for your attention.